Hello, my name is Sepideh Amin-Hanjani. I'm a neurosurgeon at University of Illinois at Chicago and a member of the ISC Program Committee. It's my real pleasure to be here with Tudor Jovin, one of the lead investigators of the AURORA collaboration. Dr. Jovin is no stranger to many of us, given his lead role in many of the acute thrombectomy trials of recent years. He is currently director of the Cooper Neurological Institute at the Cooper University Healthcare System in Camden, New Jersey. And he's also vice chair of the ISC Program Committee this year. So Tudor, real pleasure to have you here. Let's start out by having you tell us a little bit about the AURORA collaboration and what this study aimed to do.
Thank you, Seppi, for having me. The AURORA collaboration is an individual level patient meta-analysis that has put together all patients randomized to either thrombectomy plus best medical therapy or best medical therapy alone in patients randomized beyond 6 hours from last seen well, from 6 hours to 24 hours.
And what do you feel this pooled data from these randomized trials has shown us beyond what the individual trials were able to do?
So the pooled analysis allowed us to a more precise estimate of treatment effect, and also gave us the more power for subgroup analysis. It also included a more heterogeneous group of patients with respect to selection, as some of the trials that make up AURORA did not require, just like DAWN and DIFFUSE, quantitative mismatch analysis, and included patients from a more heterogeneous group of patients with respect to geography.
Can you share with us what the main results of the study were?
The main results of the study was that there's a 2.5-fold higher chance of being less disabled after thrombectomy compared to best medical therapy. That translates into a number needed to treat of 3 for reduction of disability, which is quite impressive, and it is no less powerful treatment effect than that seen in the 0 to 6 hour time window. In terms of subgroup analysis, there are several important findings. Number one, there is no difference in treatment effect, or there is benefit noted throughout all modes of presentation, whether you are wake-up strokes versus witnessed onset, whether or unwitnessed. Number two, there is no heterogeneity of treatment effect with respect to DAWN and DIFFUSE 3, which used quantitative mismatch analysis versus the other 4 trials that did not require quantitative mismatch analysis, and some of the trials didn't require any perfusion imaging at all. So these are important findings in terms of subgroups. The other important finding in terms of subgroup is that there does not appear to be any significant difference in treatment effect in patients with highest aspect scores versus moderate aspect scores at a dichotomized value of 7, even though, of course, by design, all these trials did not allow patients with aspect scores of 5 or less. So we don't really have much information of benefit in this category of aspect scores. And perhaps the most important finding from the subgroup analysis which is why I left this for the end, is the fact that while there is benefit of treatment in both patients randomized in the 6 to 12 and 12 to 24 hour time window categories, the treatment effect, the degree to which patients benefit, is stronger in the later time window than in the earlier time window. And it is important to make the distinction between prognosis and treatment effect. In terms of prognosis in treated patients, nominally there is a slightly higher rate of good outcomes in patients treated earlier. However, if we look at the treatment effect, the delta between treatment and control groups, the benefit is much stronger in patients randomized in the late time window. And we think that this has to do with the fact that patients who present later in time have a lower chance of spontaneous recanalization compared to patients who present earlier in time. And so we think that this is a really important observation, that the benefit is maintained throughout the all time epochs from 6 to 24 hours, but appears to be stronger in later presenting patients.
What do you think are the main clinical implications of these results in current practice?
But the main clinical implications are that people should be less reluctant to treat patients according to mode of presentation, that there should be less concerns in patients with moderate infarct, and more importantly, and possibly also as a change of guidelines, so to speak, that treatment in the over the entire 6 to 24 hour time spectrum should be considered equally beneficial, if not obviously more beneficial in the late time window.
All right. Well, thank you very much, Tudor, and congratulations on your presentation.
Thank you, Sepi.